Good morning to one and all, and welcome to this webinar on addressing the recent measles outbreak hosted by the Academy of Science of South Africa. My name is Kujo Palani. I am a program officer responsible for health and related sciences within the Academy, and I'll be your program officer. I'll be the program director for this webinar. So just to give you a brief background to this webinar, in recent months, South Africa has been grappling with the concerning resurgence of measles, a highly contagious viral disease that had been largely under control for several years. The outbreak has raised serious public health concerns and necessitates immediate attention and intervention. Measles is a vaccine-preventable disease, and its resurgence can be attributed to various factors, including but not limited to suboptimal vaccination coverage, waning immunity, and the challenges posed by the ongoing COVID-19 pandemic. This outbreak is a stark reminder of the impact of a pandemic that has strained the healthcare systems and diverted resources. The aim of the webinar today is to understand the factors contributing to this resurgence and to explore successful strategies employed to contain and manage measles outbreak and potentially propose recommendations for immediate response and long-term prevention strategies to curb the measles outbreak and, importantly, to prevent future recurrences. I'd like to thank you all for your presence and your interest in this webinar as we embark on a collective endeavor to address this pressing topic. To help us unpack the topic, we are joined by three panelists: Dr. Kerrigan McCarthy from the National Institute of Communicable Diseases, Dr. Lesley Bamford from the National Department of Health, and Professor Rudzani Muloiwa from the University of Cape Town. Before we get to the presentations, allow me to welcome the Executive Officer of the Academy of Science of South Africa, Professor Himle Sudiel, to give her opening remarks. Over to you, Prof.
Thank you so much, Kutso. Good morning, colleagues, and thank you to our speakers for generously giving us of their time to bring us into the spirit of understanding the science behind measles. I'm a Hindu, and when I was growing up as a kid and had measles, we followed certain cultural practices. One, the tradition belief was that the child who had measles was possessed by one of the demigods. And as such, our parents, kind of welcomed the demigod into the house. And there were certain things that that child had to observe together with the family. First, the child was isolated in a room with no leather and no shoes were allowed in that room. Also, at the entrance of the house, a little container, what we call a lota, would have been placed outside with some slingerberry leaves and turmeric in it. And visitors were not allowed to enter. And normally, if Hindus would see something like that at the doorstep, they would know that there is somebody with measles and they will not enter the home. The other thing was that the child and the entire family would eat boiled food. Now that practice is still practiced today in many parts of South Africa, even though we know what the causative agent of measles is, that it's a viral infection, etc. But the point I want to make is that certain traditions became religious, became practice that even in the modern era is still practiced today. Now, in many instances, when it concerns certain diseases, we sometimes preside over our culture and traditional indigenous practices without the acknowledgement of the evidence that is provided by science. And therefore, I am very, very thrilled that Kutso has arranged this particular webinar, because with the imminent lineup of speakers we have today, we will learn about measles, its transmission, and what it is we should know about the disease. So with that, colleagues, I just want to punt, since I have the floor, a little announcement in addition to the program for today. On the 9th of November, ASSAf will be hosting its first national conference of its members. And it's the first time that we're doing it, and it will be held in conjunction with our annual general meeting in the afternoon and our events and inauguration of new members in the evening. The theme for that conference is going to be on the poly crisis, and that is the bringing together of the address of global challenges that affect us in an interrelated way. So to all members and people on the panel in the participation, we welcome you to look at the announcement and please register timelessly to attend. Thank you, Kutso, and sorry I hijacked the last bit, but I think it's important for people to be aware of forthcoming attractions. And with that, I look forward to listening to what I believe is going to be a rather interesting lineup of talks. Thank you all, and once again, welcome to everyone to this webinar. Over to you, Kutso. Thank you.
Thank you so much, Prof. I, for one, am also very excited with the lineup of speakers that we have. So in terms of procedure, I'll introduce each of the speakers, and then they'll all give their presentations, and then we'll have a Q&A session after all the presentations. Colleagues may post their questions in the Q&A box, and panelists are welcome to answer their questions as and when we go along. If the time allows, then colleagues can put up their hands during the Q&A session, and they will be granted permission to raise their question. Thank you. So our first speaker is Dr. Kerrigan McCarthy, a specialist pathologist in microbiology. Dr. McCarthy has a wealth of experience in quality assurance, mycology, and has done extensive work in health system strengthening for TB and HIV integration. She has a strong background in coordinating national evaluations and supporting responses to outbreaks. Dr. McCarthy today will be providing an overview of measles and measles control strategies, also covering rubella and joint elimination of measles and rubella. Over to you, Dr. McCarthy.
Morning, Kuto, and listeners, and greetings, Himla. And what an honor to be able to share with you all this morning. I am going to be sharing on progress towards elimination of measles, as Kuto shared, and I'll be speaking from my role as a pathologist at the Center for Vaccines and Immunology at the NICD. I hope that what I share with everyone will pave the way for my colleagues, Lesley Bamford and Rudzani Muloiwa, to speak to both the South African outbreak and the global agendas for elimination of vaccine-preventable diseases. So I'll cover briefly the basics of measles, the virology and epidemiology, and then look at some international context, and then briefly look at what we need to do in South Africa to own the measles elimination agenda. So I always used to be very bored about virology when the lecturers at university put up the slides, or if I had to read the foundational chapters of the virology textbooks to try and understand what this pathogen was all about. But as I've gained experience in the very practical fields of controlling outbreaks and supporting health programs, I realized that it all starts with the virology. It is absolutely helpful to understand the enemy, so to speak, and to be able to relate the different facets of the virology and pathogenesis to the crucial aspects of infection transmission and infection prevention and control. And that, of course, includes outbreak response. So the measles virus is a deceptively simple virus. It's a negatively stranded RNA a strand that comes enveloped in a human cellular envelope that has some key proteins on the outside of the envelope that facilitate the binding and internalization of the measles virus. Essentially, the virion has 6 structural proteins and 2 non-structural proteins. But what is perhaps critical about measles, and something that we can be quite appreciative of, is that measles has a single serotype. And that means that the antigenic structure on the surface of measles, particularly the hemagglutinin protein, the H protein, and the F protein, the fusion protein, are stable between the different genotypes. They're antigenically stable. The proteins have the same structure. And this means that antibodies against different genotypes of measles are cross-reactive. And that despite the genetic differences that lead to different clades, and there are 8 clades of the measles virus, all of them have the same basic antigenic structure. And this means that a measles vaccine that elicits antibodies is not susceptible to different strains of the virus. So contrast that, for example, with human papillomavirus, where there are an enormous number of different viral epitopes that lead to the different HPV serotypes. And this allows or means that if we are to launch a vaccination campaign against HPV, we have to include multiple serotypes of the vaccine in our vaccine candidates. Whereas with measles, because there is only a single serotype, the measles vaccine elicits neutralizing antibodies to all measles strains. The second most important thing about the virology of measles is that it is an obligate human infection. There are no animal reservoirs of measles virus. The virus cannot cause infection in other animals to any significant degree. And so that means that there is no host for measles infection other than humans. And again, if we think about zoonotic transmission and crossover of measles virus, or at least not measles virus, other viruses, SARS-CoV-2 being the most recent example, we do not have this problem with the measles virus itself. And this lends itself at a very basic virological level to an elimination agenda. The other important thing about measles is the fact that it has a unique mode of entry that is able to change and morph as infection progresses. So the measles virus itself is transmitted through inhalation of vaccine or virus particles, and it attaches to the CD150 cell surface receptor that is found on lymphocytes and lymphocyte-related cells, macrophages, dendritic cells. And of course, these cells, the alveolar macrophages particularly, are in abundance in the respiratory tree. And what we find is that after internalization, the measles virus shifts its cell receptor type to the nectin-4 receptor type. And this is found on the basal surface of epithelial cells. So what happens is that the measles virus enters through the respiratory tract, is internalized by dendritic cells, which then disseminate through cell-to-cell association, disseminate the virus systemically. However, at a certain point during the infection and during the incubation period, which is around 9 to 14 days, the virus shifts its cellular tropism to this nectin-4 receptor, and it re-enters the respiratory tract. And this time, the entrance of the virus leads to a destruction of respiratory epithelial cells. And it's this symptomatology, or this phenomenon, that leads to the symptomatology of a marked cough and respiratory symptoms, coryza, runny nose, conjunctivitis, and then may in immunocompromised persons lead to a pneumonia or a giant cell pneumonia. And The other important thing about this initial B cell tropism is that it leads to a widespread destruction of the infected B cells. And this means that it leads to a loss of humoral immunity to a wide range of pathogens, and this can last for as long as 6 to 12 months after infection. In fact, in resource-poor countries, it has been conclusively shown twofold. Number one, that persons infected with measles children particularly have a higher all-cause mortality following measles infection during the first 6 months after measles. And secondly, that measles vaccination increases or decreases the all-cause mortality in places and children who have, and communities that have been vaccinated with measles. An amazing association with the ability to improve health at a global level and at a population level by simply vaccinating with measles. And this is mediated, and we understand it through the basic virology of this condition. So how does measles cause infection? Well, the organism, as I said, is excreted through the respiratory tract epithelium, or epithelial infected material excreted along with infectious secretions and coughs. And it has a very, very high infectivity. In fact, measles virus has, secondary to polio, has perhaps one of the highest reproductive numbers of infectious diseases seen today, and that is around 8 to 18. So for every infectious case, we see between 8 and 18 secondary cases. Contrast that with influenza, which has an effective reproductive number of around 2 to 3, and you'll appreciate why outbreaks of measles can be explosive, even in contexts where a relatively high proportion of persons are vaccinated. Now, measles, as I shared, has an initial viremic period disseminated to systemic infections, to organ systems, and then re-enters the respiratory tract. And on the re-entry to the respiratory tract, persons become symptomatic. And the initial symptoms are related to the invasion of the respiratory tract. A person develops a cough, and one of the 3 C's, we call them coryza, cough, conjunctivitis, and a fever. And it is only on the 4th day, and this is almost unchanging over the time course of measles infection, different populations and different eras. On the 4th day after these so-called prodromal symptoms commence, the measles rash appears. And from an epidemiological perspective, we count this, the day of appearance of the rash as day 0 of infection. And you'll see on this time course over here that on day 0 signals the middle of the infectious period. The rash of measles, a maculopapular rash, is in fact a immune-mediated response and signifies the onset of successful humoral immunity that then curbs the viral cell-to-cell movement. This measles rash is interesting because it is an immunological feature, and in persons who have immunosuppression due to any cause, the rash does not appear. I was involved in an outbreak in 2015 in an oncology unit where a person had prolonged fever and pneumonia, and eventually a giant cell pneumonia was diagnosed, and the patient never actually presented with a rash. Now, because measles is so infectious, the herd immunity threshold is around 95%. This means that we need to vaccinate at least 95% of persons in order to ensure that the entrance of measles into a community does not lead to ongoing transmission and an outbreak. So a little bit about the measles vaccine. It is a vaccine that has been around since the 1960s. It is perhaps one of the safest vaccines known to humankind. It is a live attenuated vaccine, and it is very successful. It induces seroconversion in around 97% of persons, and it has lifelong immunity, although there is some element of waning of vaccination, but at an incredibly slow rate of 0.009% of vaccinated persons per annum. The perhaps Achilles heel of the measles vaccine is that in lyophilized form, it is highly stable, but after reconstitution, it is thermally unstable, and it loses about 50% potency for every hour at 22 degrees. And at 37 degrees, it becomes completely non-immunogenic after an hour. And this means that it creates very difficult conditions for programmatic distribution of the measles vaccine. And these are perhaps even more exacerbated during measles outbreak response campaigns. As I said, the vaccine itself is highly safe. There are contraindications, and these relate to the fact that it is a live attenuated vaccine. It should not be given to persons with underlying immunodeficiency, and that includes pregnant women. There may also be some relative contraindications due to persons with concurrent diseases that are immunocompromising, or in which the vaccine itself may elicit untoward effects. The adverse effects are limited. The commonest adverse effect relates to the fact that it is, and all measles vaccine strains are related to wild type in the genealogical tree that you see on the left. 1 in 20 persons will develop a rash and a fever 6 to 12 days post-vaccination. And the reason for this is that the virus itself elicits some of the symptoms that its parent or genealogical progenitor elicited, that is the fever and rash itself. And very rarely, the vaccine will elicit some of those complications that the wild-type strain will elicit. So we see immune-mediated thrombocytopenia, post-infectious encephalitis, as well as adverse effects related directly to the vaccine or to the physiological processes that we see. So that occur normally. So febrile seizures and hypersensitivity reactions to vaccine components are obviously going to happen. Of interest, the vaccine strain that we are currently using is the CAM70 strain, and this is found in the MEAS-Bio vaccine. However, the tender has expired and a new tender has been awarded, and this will go to a company called Cipla, which I think uses the Edmundston, Zagreb, and the Moreton strain as the vaccine component. It's helpful to look at measles epidemiology prior to the 1960s when the vaccine was introduced. And this lovely epidemiological curve comes from a paper published describing the epidemiology of measles in England and Wales going back to the 1950s. And what you'll see on the horizontal axis here is that every second year is annotated. So it's 1950, 1951, 52, 53, etc. And you'll see that prior to the introduction of the vaccine in 1968, that measles outbreaks occurred every second year. Now, this is an interesting epidemiological phenomenon because if one assumes a population is either relatively constant or growing, there will be marginal increases in the number of new children born every year. And essentially, the number of new children born this year should equal the number of children born last year, and perhaps a little more. And what this epidemiological curve illustrates is that as the population size doubles, and arbitrarily half the population is unvaccinated, the conditions are ripe for a measles outbreak. This dictum still holds true in the post-vaccination era. What we have noticed is that when the susceptible population, in other words, those who are unimmunized, reach the size of the annual birth cohort, a measles outbreak will occur. And so you see, firstly, a marked reduction in the numbers of cases, where in thousands, that is the axis, but we still see a seasonal pattern of an increase in number of cases, in this case, perhaps every 2 years. What we've observed in South Africa is that we have a vaccination coverage of around 75%, and that means that 25% are unvaccinated, more or less. And if we reckon that we have a birth cohort of around 1 million babies born a year, every 4 to 5 years, the size of the unvaccinated cohort reaches the size of the new birth cohort, the annual birth cohort. And the conditions are ripe for an outbreak. And if we look, and I haven't got them today in our presentation, but we can see that we have surges in measles outbreaks every 4 to 5 years. This has implications for measles control. What it means is that we need to keep tabs on two things. The first is our vaccination coverage rate, and the second is when our last supplementary immunization activity occurs. The World Health Organization advises that if we cannot keep the vaccination coverage over 95%, that it is advisable to do a supplementary immunization activity at a time period that will ensure that a measles outbreak will not take place. And there have been a number of global modeling exercises that have attempted to use the seroprevalence of measles to determine and model when this period is. The other option in terms of measles control is not to do supplementary immunization activities, but to implement an outbreak campaign as soon as a critical number of measles cases are identified, recognizing that one does not have sight of the background seroprevalence, and that a supplementary immunization campaign or an outbreak response activity can mop up and eliminate those persons in the population who remain susceptible and therefore prevent transmission of an outbreak. So with this tool, the measles vaccine, immense successes have been achieved. If we look at this map from our World in Data at the number of measles cases reported globally from 1974, we just look at the intensity of color in the map, and we can see that there's an incredible amount of measles. And in fact, if we move to the graph for the most recent available data, 2021, we can see that remarkable success has been achieved across the globe in terms of eliminating measles cases from the globe. In fact, from a review article that I'll give the reference just now, around the decline in reported measles cases over the 1990 to 2019 period was from 80 to 12 million, with a decreased age standardized incidence rate from 1,200 per 100,000 to 191. And this is entirely due to the success of the measles vaccine in preventing and controlling measles. We have seen similarly a reduction in the distribution of measles genotypes. I said that there were 8 genotypes with a number of subgenotypes, and since 1990, or in 1990, there were around 19 genotypes detected. And you can see the global distribution of these. The current WHO molecular epidemiological page of the measles control program shows the current distribution of genotypes. And since 2018, there have been only 4 genotypes identified in global surveillance. These include B3, D4, and D8, and H1. And you'll notice the absence of a blob in South Africa. And the question is, what do we have? And I'll tell you in a minute. Measles genotyping is based on a 450 nucleotide sequence region between the N gene and the next adjacent coding region. And this technology was developed in the early 2000s, and with the decline in the number of circulating seroprevalence or circulating genotypes, the techniques that are required going forward will include the need for whole genome sequencing rather than just this very short, rather polymorphic or pleomorphic section of the measles genotype. In South Africa, in this most recent outbreak, we've detected two genotypes. The first is genotype B3, and I'm not sure if you recall, but prior to the measles, current measles outbreak that started around about October, there were a few cases in the Gauteng region that were alerted to authorities. A measles vaccination campaign was conducted in the affected areas, and you see in the graph on the bottom, the epicurve, the number of cases. The axis is very low, it's only 3, but the axis on the right shows the number of vaccines administered by the City of Tshwane district health authorities in and around schools in the affected area. And this virus strain did not persist. The phylogenetic tree on the right shows with the red dots those isolates that came from the Tshwane area and their relationship to other strains in the Southern African continent. You'll notice the words Zambia and Uganda. And in fact, these strains were related to an outbreak from Zambia in 2022. The second genotype that we have detected was genotype D8, and this virus strain was responsible for the widespread outbreak that that Lesley will speak to. This virus was imported from Zimbabwe, which had an outbreak in July to August of 2022. And our strains that were genetically related to this outbreak were isolated from the Vembe and Sekhukhune district in Limpopo, of course, indicating likely cross-border transmission. So we're achieving great successes in measles elimination, but if we take another look at these wonderful curves that show the reduction in the number of measles cases, and we stratify them by a socio-demographic index, we'll notice that countries that have a high socio-demographic index, such as those in the green, have a very marked reduction in the number of measles cases in millions on the vertical axis. However, the countries in the low socio-demographic region do not show the same trend. And in fact, there has, at present, countries that have a high socio-demographic index have a much lower measles index, much lower measles incidence compared with countries with a low socio-demographic index. And so our achievements at a global level are perhaps more in keeping with provision of healthcare services, vaccination, and living conditions than they are attributable to the vaccine itself. What is of note is that measles was eliminated twice in the PAHO region. In 2002, the Americas were declared measles-free. Measles was imported and became entrenched in the PAHO region subsequently. It was controlled and the PAHO region was declared measles-free. And then the same thing happened again. Measles was imported. And the learning lesson here is that the globe cannot rest until measles has been eliminated everywhere. Like SARS-CoV-2, measles somewhere is measles everywhere. And the question is, what has happened that has led to a global resurgence and failure to eradicate measles across the globe? Essentially, measles is driven by social upheaval. There are measles resurgences in areas with wars, with droughts, with humanitarian crises, followed by transmission within and amongst migrant populations, and then followed by global dissemination through air travel and trade. In countries that are relatively unaffected by these kind of crises, there still remain health system challenges in vaccine delivery, and this impacts on our ability to achieve this 95% vaccination coverage. To compound matters, there is growing vaccination hesitancy or lack of vaccine confidence, and this led to, and you'll notice over here, the red represents the Euro region, a resurgence of measles cases in countries where vaccine hesitancy was the biggest driver in failure to vaccinate. We also see legacy low vaccination coverage in older age groups with reintroduction of the virus. And a frequently asked question is about the impact of waning immunity. With a waning immunity of 0.009% per annum, measles vaccination is not considered as a vaccine where adult vaccination or revaccination is routinely required. If a person has seroconverted due to primary measles vaccination, there is in fact no need to revaccinate. And in the context of a successful immunization program, these very small proportion of people who in fact do become susceptible should not constitute a risk if there is adequate vaccination coverage across the world. So how has the WHO responded? The WHO has suggested or has developed a measles and rubella strategic framework for 2021 to 2030. Although 2020 was set as the target for measles elimination, it wasn't achieved, and there have been some key revisions and learnings that have been incorporated from the other programmatic attempts that have delivered vaccine. The choice to combine measles with rubella was based on some unique properties shared by both viruses. Like measles, rubella has a single unchangeable serotype. The virus does not have an animal reservoir. There is an effective and safe vaccine that is easily manufactured. And so, because the vaccine administration channels are identical, it seems pragmatic and prudent to attempt to eliminate both of these viruses at the same time. And so the WHO envisages a world free of measles and rubella by 2020. So learning from the lessons of other programmatic disease elimination campaigns, the WHO has put together some principles and strategic priorities to ensure measles vaccination, measles elimination. The principles include country ownership, partnership-based rather than centralized vertical control, the fact that the program needs to be people-focused and driven by data is a key learning lesson from the polio campaign, from the polio vaccination program. The document also aligns the strategic priorities with some of the development agendas that are presently in operation. Key is a topic called universal health coverage, where measles vaccine, rubella vaccine needs to be integrated into primary healthcare as part of universal healthcare and not as a standalone program. This, of course, has been learned from the polio program, where vertical control has led to an incredible wastage of resources, where individuals and staff members and expenses are utilized exclusively for polio, when it's a simple matter to integrate other programs into polio and have win-wins all round. Commitment and demand, coverage and equity, life course integration, outbreak emergency and response, supply sustainability, and research and innovation are other key strategic priorities that the document highlights. So how do we own this agenda for ourselves? Just to give you a brief snapshot of measles over the last 30 years, there were outbreaks in the mid-1990s. In 2003 to 4, South Africa experienced an outbreak of over 2,000 measles cases. The largest measles outbreak in our generation occurred in 2009 to 2011, with over 22,000 laboratory confirmed cases and many more. 2017, we had a small outbreak of 300 cases, and this most recent outbreak is the largest since 2011. There have been sporadic cases occurring in between years, but essentially the build-up of susceptible persons has been controlled and prevented by the provision of supplementary immunization activities by the National Department of Health. So what does this mean for us? A key thing that we need to do in South Africa is address the root causes of under-immunization. Dr. Portia Mutavedzi, in the household vaccination coverage study conducted at the end of 2019, demonstrated an average vaccination coverage of around 75 to 80%, and this is not high enough to eliminate measles. The wonderful document produced by your organization beautifully summarizes the root causes of low vaccination, and I don't need to repeat these. From the NICD perspective, there's lots that we can do to strengthen surveillance and epidemiological assessment of the measles status of our country. We need to understand the seroprevalence. We need to close the surveillance gaps, including develop a better understanding of morbidity and mortality. We need to have ongoing evaluations of vaccine effectiveness. We need to better understand our molecular epidemiology and explore novel surveillance techniques like wastewater-based epidemiology. A critical thing and new on the global horizons is the development of point-of-care or rapid diagnostic testing for both measles and rubella, as this will facilitate outbreak response and ring vaccination to contain outbreaks as soon as possible. Our surveillance processes and procedures are the backbone of measles surveillance in South Africa. And what is not done often enough is the collection of throat swabs in order to facilitate measles vaccination, measles serotyping and genotyping. And this is something that the NICD can do to support clinician awareness of our fever rash surveillance program and allow us to develop better molecular insights. And so with that, I'm going to hand over to Dr. Lesley Bamford, who will give us a hands-on and up-to-date assessment of the measles outbreak as it stands. I hope that I've given sufficient background information to support some insight into some of the challenges that we face as a country and as a globe to support measles elimination. Thank you.
Thank you so much, Dr. McCarthy. And it really gives better insights so that we can better understand the enemy, so to speak. So our next speaker is Dr. Lesley Bamford, a pediatrician who has been an integral part of the Child, Youth and School Health Chief Directorate in the National Department of Health since 2006. Her experiences bridges the gap between research evidence and policy, program design, and the implementation of national health initiatives, with a primary focus on maternal, newborn, and child health services, as well as contributing significantly to the COVID-19 response and vaccine rollout efforts. Dr. Bamford will be talking to us about the recent measles outbreak. Over to you, Dr. Bamford.
So thank you very much for that introduction and for the opportunity to present during this webinar. So I will be talking about the recent measles outbreak in South Africa. So really trying to, the practical side of, we know the theory, and it was great to hear it explained so clearly in the previous presentation. But what does this mean for delivering health services, vaccinating children, and protecting them from measles? So I think Kerrigan already presented this slide, and it shows that we do have a reduction in the number of cases of measles in South Africa, but we are susceptible to outbreaks, with the last significant outbreak being experienced in 2009 to 2011. So really, what are our strategies for measles elimination? First of all, vaccination, routine vaccination, and that needs to really be the foundation of our elimination efforts. Then supplementary vaccination campaigns, SIAs, as explained in the previous presentation. We need to have strong surveillance. And then, of course, we need to be ready to respond to outbreaks. So I'm going to start by talking a little bit about vaccination in South Africa. So every child born in South Africa receives a Road to Health booklet, and the Road to Health booklet contains the child's immunization schedule. In the public sector, we offer 2 doses of measles vaccine to every child at 6 months of age and at 1 year of age. But from 2024, this will be combined with measles and rubella, but the schedule in terms of the timing of the doses at 6 months and at 12 months will remain unchanged. In the private sector, children are offered 1 dose of measles, mumps, and rubella, and that vaccination is provided a little bit later. This slide then shows our coverage. So remember that in the previous presentation, it was noted that because of the high reproductive number for measles, to eliminate measles, to stop circulation of the virus, we really need to achieve high vaccination coverage, around about 90 to 95%, and that's 2 doses of measles vaccine. So on the left-hand side, you can see where we are in South Africa. And in recent years, we've managed to vaccinate approximately 85% of children. This does exclude children vaccinated in the private sector, but we know that the private sector only contributes a small number of vaccinations to our national target. So 85% of children should be protected, but that means that 15 to 20% of children are unprotected and at risk of developing measles. On the right-hand side, you can see the figures from the provinces with quite a lot of variation between the provinces, but most provinces have been showing increased vaccination coverage, but as again, not to the levels that we would like to see. So because we know that there are that the immunity gap was growing, a measles vaccination campaign was planned for February 2023, and that campaign targeted children under 5 years of age, which includes approximately 6.9 million children in South Africa. Again, this was touched on in the previous presentation, but why do children not get vaccinated? These are the data from the immunization survey, which showed that there are a number of reasons. Many parents were not aware that their children needed to be vaccinated. We know that there are issues related to supply. So there are stockouts in our facilities. Our caregivers take their children for vaccination and are turned away for various reasons, most often because of lack of stockouts of the measles vaccine. Other parents said that the facility was too far, that they forgot to take the vaccine or the child for vaccination, or there was no one to take the child for vaccination. So a variety of health systems and knowledge issues contributing to children not being unvaccinated or undervaccinated. With vaccine hesitancy, it would seem in childhood vaccination program playing only a small role. I think I'm actually going to skip through this slide and move on then to talk about the current the current vaccine or the current outbreak. So again, this was touched on in the previous presentation. So late in May 2022, there was a cluster of measles cases in Gauteng, about 11 cases. These were related, as you heard, to the B genotype, but due to a very rapid response with vaccinating in hotspots, identifying contacts, this small outbreak was contained. However, we know that there was a much larger measles outbreak in Zimbabwe that started in April 2022 and peaked in August of 2023. At the end of October, it was reported that there were more than 7,500 cases and 747 deaths were reported. Although it must be said that this has not necessarily been verified. But certainly in Zimbabwe, there was a large outbreak with many children dying as a result of measles. There was a response with more than 1.5 million children receiving a dose of measles vaccine with a coverage of about 70%. And as a result of that, the outbreak was controlled. However, clearly there was a cross-border spread. So in September of 2022, sporadic cases were detected in Sekhukhune district in Limpopo. And in October, the province met the outbreak threshold for declaring a measles outbreak. I think it's important to note that the epidemic threshold for declaring a measles outbreak is very low because of the high level, because it spreads so rapidly. And so a measles outbreak is declared when 3 or more cases of measles occur in a health facility or a health district in 1 month. So following the outbreak being declared, there was immediate ring vaccination in creches and villages of children up to 5 years of age. And then quite rapidly, cases were also detected in other provinces, predominantly in Mpumalanga, Northwest, and Gauteng. Free State, Northern Cape, KwaZulu-Natal, and Western Cape also reached the threshold for declaring an outbreak, although I'll show you shortly that they had far fewer cases. So the only province where no outbreak that did not meet the threshold for declaring an outbreak was the Eastern Cape. This slide then shows the curve, the number of cases, how the outbreak proceeded. You can see the green cases are in Limpopo. So most of the cases were there, with quite rapid spread then to Mpumalanga and Northwest, and then later to Gauteng. What we can see here, and I'll talk a little bit more about what we did. So essentially, in response to this outbreak, we needed to bring forward the vaccination campaign. But just back first to a little bit about the numbers. This slide is taken from the report issued each week by NICD. And on the left-hand side, it shows the epi week at the beginning of the outbreak, and then the most recent weeks. We are almost exactly a year from the time that the outbreak was first declared. And so you can see along the bottom the provinces that were most affected. 524 confirmed cases in Limpopo, 228 cases in Gauteng, 222 cases in Northwest, and 120 cases in Mpumalanga. And then smaller numbers in the other provinces. So what was a little bit unusual about this outbreak compared with other outbreaks? So in general, we expect to see the highest number of cases in younger children, often children under 1 year of age and children 1 to 4 years of age. However, in this outbreak, the majority or the highest number of cases were in slightly older children, children 5 to 9 years, 10 to 14 years, and even some cases in children 15 years and above. As a result of this, the National Advisory Group on Immunization, NAGI, which is the committee that advises the minister on issues related to vaccination, recommended that the target population for the campaign, the planned campaign, should be expanded to include children up to 15 years. And this meant that the target population arose from 6.2 to 17.7 million children. This is a slide I pulled out from when we were planning for the responsive vaccination campaign. And really just to flag just how complicated it is to rapidly respond in this manner, to try and in a short period of time to vaccinate 17 million children in South Africa. In terms of what was done, a national response plan was compiled. An incident management team with work streams was established, and they met regularly. We started the campaign for children 6 to 59 months immediately because a vaccine was available as planned for the planned campaign, but provinces were also requested to, as rapidly as possible, replan and target children 5 to 15 years as well. This slide just quantifies the additional resources that were required to expand the scope of the vaccination campaign. And the figure to note is the figure in the far right-hand corner, that the cost of the campaign aiming for 75% coverage was approximately 240 million rand, just to cover the vaccines and the consumables with no costing or additional resources being made available for actual administration of the vaccines. One of the issues in South Africa is that whilst when we do a vaccination campaign, we would like to reach 90 to 95% of children, coverage has tended to be low in our vaccination campaigns. And for that reason, we used a realistic coverage target of 75%. This slide then shows the coverage that was achieved during the vaccination campaign. So the blue is children 6 to 11 months of age. The orange is children 1 to 5 years. And the gray then children 5 to 15 years. And one can see that the coverage declined in the slightly older age groups. Our provinces used a range of strategies to reach children, vaccinating children, of course, in our primary healthcare facilities, but also in creches and ECD centers, and then targeting older children through vaccinating them in schools. We were able to link the measles vaccination with the HPV vaccination campaign, which takes place in primary schools from during February and March. And that facilitated vaccination of older children. but nevertheless, there were challenges with regards to achieving high coverage, particularly in the older age groups. Overall, during this period, approximately 11 million doses of measles vaccine were administered, and that represents approximately a coverage of round about 60% of all children under 15 years in South Africa. One thing just to mention was that Limpopo province took a decision not to vaccinate all children up to 15 years of age during the first phase of the vaccination campaign. And one can see in the epidemiological curve the impact of that. So a large concern with spread of the outbreak was what would happen once schools opened in South Africa. We had a lot of children congregating at the beginning of the school year and a very high risk of spread. So there was a real urgency to vaccinate, and most of the provinces started vaccinating in December and January across the full age group. And as a result, in most provinces, the outbreak was controlled, but we saw more cases going into 2023 because in Limpopo province because of the delay in starting to vaccinate that age group. And that really demonstrates the fact that when we do a campaign, it is both about protecting the individuals, but also we would like to vaccinate over as short a period as possible in order to ensure that we interrupt circulation of the virus. So in conclusion, the current outbreak has been controlled, although sporadic cases continue. And you may have noticed in the slide I showed, there are still 3 provinces where the outbreak has not yet formally been declared over. The outbreak was a little bit unusual in that cases occurred in older children. No deaths have been reported, although we know that we do not have sensitive mortality surveillance in place. So it is possible that deaths both directly due to measles and indirectly are not identified. Increasing routine vaccination coverage and strengthening of surveillance are key to eliminating rubella. Evidence from the outbreak suggests that vaccine effectiveness remains high. However, we do on an ongoing basis need to review our vaccination schedule. We need to think very carefully about supplementary immunization activities, mass vaccination campaigns. These are very effective, but they do take a lot of resources within the health sector and do have many opportunity costs. Responding to outbreak places significant strain on an already overburdened healthcare. And then the last point is that although vaccine hesitancy played a limited role in this outbreak, we know that vaccine hesitancy is on the rise in South Africa, and it's something that we need to track very carefully. Thanks very much.
Thank you very much, Dr. Bamford, for that presentation. Our last speaker is Prof. Rudzani Muloiwa, a pediatrician with expertise in infectious diseases, particularly vaccine-preventable diseases. He currently holds the esteemed positions of Professor and Head of Department of Pediatrics and Child Health at the University of Cape Town and the Red Cross War Memorial Children's Hospital. He co-directs the Vaccines for Africa initiatives and plays a key role in national and regional immunization advisory groups. Prof will be speaking to us on the role of vaccines in the elimination of vaccine-preventable diseases and the challenges experienced both locally and globally and in South Africa. Over to you, Prof.
Thank you very much, Kuto. Can you hear me and can you see my slides?
Yes, we can.
I'll try to go a bit quick. I think fortunately my two colleagues have covered some of the aspects that I may have spoken about, so that I'll be able to hide some slides. So I'll talk very broadly because I just think it's important for us to kind of appreciate the value of vaccines in terms of elimination and also eradication, which is particularly important when you're thinking about measles, including what Kerrigan pointed out, that measles is an exclusive human pathogen with quite a possibility of actually getting rid of the virus because it's got nowhere else to go to hide if we can vaccinate properly. So usually when we talk about our story of immunization and vaccination, it probably takes us a very long back to the fact that human beings have always understood that if someone gets an infection, they tend to no longer get another one. And we have known this for a number of conditions, that if you get sick and you get well, then you may not get measles again or chicken pox or any such. And this led in the early 1700s when Lady Mary Montagu was actually accompanied her husband, the Lord Montagu at that stage, to be an ambassador in Constantinople in what was then that Turkish Empire. And when she was there, she actually learned about this trick that people from the Caucasus used to have, where they would take scabs and pustules from someone who has had smallpox, make small incisions and rub that in, and find that their children were actually protected. Mary Montagu had herself been a survivor of smallpox, and she had lost a sibling due to smallpox. So for her, that was quite important. And she managed to take this back to London when she returned from the Ottoman Empire, which is where she was based. And then, and that became a practice in parts of the United Kingdom. But for us, the real gift probably came about 50, 60 years later, with the work of Edward Jenner, who then realized that another virus, which shares similar antigenic epitopes with variola, the smallpox, which at that time it was probably not understood in that way, but she realized that milkmaids seemed to be immune to smallpox because they've suffered from having cowpox before. And this it's one of the greatest gifts really that we've ever had as a human race with this, because the use of that virus, which was basically a live virus, vaccinia, managed to have a huge impact on this disease called smallpox. First, the numbers that used to be very, very high were reduced all over the world as the vaccinia was used to inoculate against smallpox. And in fact, on the 8th of May, 1980, the World Health Assembly, the 33rd sitting of that conference, declared the world free of smallpox, which is why even today we no longer vaccinate against smallpox, because the disease has not just been eliminated from all over the world, but has been eradicated. And that's quite important as a value of that. And taking from that time of vaccinia, other vaccines that are developing, a major jump actually happened with Louis Pasteur here, who then realized that by growing an organism around multiple cycles, its virulence factors can actually be bred out of that, and what is left retains the antigens that can be given in a live kind of format to stimulate immunity that will protect against the wild type. And this was with the chicken cholera virus that he discovered soon after, together with his student Emile Roux. They managed to dry the spinal cord of a rabid rabbit, creating an activated rabies vaccine at that stage. And this escalated in the early part of the 20th century with a number of these people, including Calmette and Gohin with the BCG vaccine, the 2 polio vaccines from Salk and Sabin, the combination of toxoids and wholesale with these ladies, Kendrick, Eldarin, and Gordon with the DPT. And then with the work of Robert Austrian in polysaccharide vaccines, the use of conjugate vaccination with John Robbins, and then the rotavirus assortment with Kapikyan, and when we talk about measles, the work of Maurice Lehmann at MSD that then gave us the measles vaccine that we use today. But what one will see is that during this time, as the science grew here on top, when we move from understanding more whether it's immunology, whether it's antitoxins, whether it's tissue culture, this development in science was mirrored by our ability to create new and quicker vaccines that can be developed with very different characteristics with that. And I think a major era arrived with the development of the meningococcal B vaccine from what is now called reverse vaccinology that brought into the vaccine space the omics era. And by the time we had all these COVID vaccines, we probably had all these kind of platforms. I mean, the vaccines that are still some in the pipelines and some that we use at the moment, they use a variety of methodology of producing those vaccines from the new technologies like messenger RNA, vaccines that use adenovector vectors, and still the traditional methods coming to bear. That by now, when we look back in all the vaccines that we have, we've got a large number of vaccines that are now routinely available for vaccinating people. And in the South African schedule, that is what we are sitting with. Now, why is this important? Well, if you start looking at individual level, when you vaccinate individuals, what you try to prevent, there are vaccines that will prevent infection. And I'll come back to them again, because that's where what I'm going to makes a lot of sense when you look at those, such as what you use for polio and measles. The vaccine prevent infection and thereby stop someone from actually having disease at individual level. But there are vaccines that will prevent disease without actually preventing infection. Tetanus is one of those, because you will still get a bacterial infection, but the toxin that is produced will be neutralized by antibodies, therefore preventing disease. And there are some vaccines that even if they don't prevent infection and disease, they can impact on severe forms of disease. Most of the COVID vaccines, that's what they've given us. Vaccines like BCG for TB may not prevent all forms of TB, but may prevent severe forms of TB. But these vaccines here that prevent infection also have got an added benefit of interrupting transmission in particular. And that gives us an important tool when it comes to public health impact of vaccination. Kerrigan spoke about elimination, which is an important goal to reach. But the holy grail is really eradication, which we have managed with in the human population with smallpox and rinderpest in veterinary medicine. But there are others that we are trying to aim for to eliminate and hopefully ultimately eradicate, like measles and polio and so forth. But the importance of vaccines, when you see them in terms of vaccine preventable diseases, is this: if we actually pedal back, for most of the existence of humankind, the life expectancy had barely touched 30 years. But the last 300, 400 years have seen this amazing jump. In fact, over the last 300 years or so, we've gained 55 years in life expectancy, with 35 of those coming back just over the last 100 years. And most of that have been gained because of our ability to be able to control infectious agents, and vaccines have been in the core of making that impact. Vaccines, interestingly, are even more valuable when it comes to reach to poor areas. If you look at this, for example, on top there, the return on investment is much higher the poorer that area is. And that's because they prevent disease, whereas people that are rich can still have a safety net of having treatment once they're infected. That is less so for poor people. So the poorer you are, the more valuable vaccines are in doing so. And in fact, Stanley Plotkin, in the opening of his book on vaccines, which is called Vaccines, he actually reflects that the impact of vaccination can only be exceeded in public health impact by just the supply of clean tap water to people. Apart from that, there's been no other intervention in the last century that has had such an impact on that. However, this is where the challenges come in. If you look at that life expectancy that I showed you earlier on, it is not equal and equitable. And this is where the challenges lie. I'm going to try to go pretty quickly because part of this has been touched on before. You can see that Africa still lags behind most of the world with respect to that. And part of that, again, is because most Africans die of preventable diseases, in particular, vaccine-preventable infections. For an example, if I just show you, when it comes to the pneumococcal conjugate vaccine, because vaccines arrived late, this was in 2000 with this vaccine. If you follow 2010, more countries said that, but you can see where Africa still stays with that. If you follow, that's when more vaccines get, but now it's more than 2 decades. There are still areas in the world, and a number of them in Africa. And this year does not even cover a very important aspect, that though the vaccines are available, they may not be equitably accessed in all these areas that are looking blue, and more so in Africa. This becomes much worse with interruption because of civil unrest and political instability. I don't think anybody is vaccinating anyone in the Sudan right now. And a number of parts of Ethiopia are probably not getting vaccinated. And if you look in the Tigray area, for example, there are areas where there have been coups in West Africa. And again, not much vaccination is taking place. And that is a major issue with the challenges that we have, especially for vaccines that need very high coverage, such as measles. I like this slide because one of the reasons this happens is that we always, Lesley has been talking about our responses and so forth to the measles outbreak. This is not as simple as that. And one of the reasons is that the cost of the vaccine dose is not the main and the only predeterminant of whether you're going to get vaccinated or not. What matters are the other things, the cold chain, the logistics. All of these things are so key and critical. And then what is even harder are the harder to reach populations that may actually get left out when it's much difficult to do so. That becomes much worse when there is a crisis. And this, for example, is what happened with COVID-19. And you can see that a number of areas had all these dips. Southeast Asia probably had one of the greatest dips during that time. And the impact of this is seen later. As both Kerrigan and Lesley alluded to, for a disease like measles, which may have that rapid reproduction number, basic reproduction number of 12 to 18, you need a very high number of people to be immune. For example, in about 93 to 95%, depending on what you regard within that context as your reproduction number. The chance of any interruption reducing that percentage is very high. And what you then get is a second situation where there are massive outbreaks of diseases all over the world. And the large proportion of those are again in low and middle income country setting and poor areas. And we've had multiple outbreaks of these. This was in 2020. And for some of us, we're waiting for what Kerrigan was talking about, where an accumulation of susceptibles because of not high enough vaccine coverage, which would then trigger outbreaks that we have seen recently that Lesley has spoken to. And so this is the issue that's there. And as I conclude, because I've just hidden some slides, it's just reflect that part of this ultimately speaks to the issue of equity. And equity should be distinctly separated from the issue of equality. You know, in a perfect world, we'll all be the same and it can just be equal. But in the real world where there is lack of equal access to resources and other people are more disadvantaged than others, what you need to aim for is equity, where more resources may have to be deployed to helping the most disadvantaged in order for them to be able to reach the same level of access to the kind of care that they require. I'll stop here because I realize that we don't have a lot of time. Thank you very much.
Thank you so very much. Yes, colleagues, indulgence maybe for 5 minutes over time so that we can have at least sufficient time to take questions. We have a question from Chris Kutsia, which is related to the planned switch in 2024 from the measles-only vaccine to a rubella and measles combined vaccine. So what will the name of the new vaccine be? Will the schedule remain on 6 to 12 months? And what are the factors that lead to including rubella but not mumps in the proposed switch? Any of the panel members are welcome to respond to the question.
I'm happy to
Dr.
respond
Bamford?
to that. So first of all, it'll be called the measles rubella, the MR vaccine. And we will continue with the same schedule in the public sector at 6 months and 12 months. So it will be a straight switch. Why we're not looking at measles, mumps, and rubella? Really for 2 reasons. The first being the fact that mumps is not necessarily considered a priority disease by WHO and by us in South Africa. We know that there was an increase in the number of mumps cases last year. But mumps generally is a mild disease with a few complications. So that's the one reason. The second, more practical reason is around affordability. So we pay approximately 20 Rand for 1 dose of measles and rubella vaccine. Currently in South Africa, the MMR vaccine is approximately 300 Rand per dose. So there is also an affordability issue. It is something that NAGI will look at going forward, but for the next 3-year tender cycle, which starts in January 2024, we will switch to measles and rubella. Rubella is considered a priority disease. It's also a mild disease, except in pregnant women, where if a pregnant woman has rubella, it can have very serious consequences for her child when the child is born. So we're really introducing it to prevent congenital rubella syndrome. Thanks.
Thanks, Dr. Bamford. The next question from Janine is, why do you think the older age group is affected in this particular outbreak? And I can link it to the next question as well, which asks why the Limpopo province decided on another route for their vaccination.
Perhaps let me come in and I'll answer the second question,
Dr. Bamford.
The question, and then perhaps Kerrigan would like to add. So I think the reasons for Limpopo delaying were around logistics, around the cost of the vaccine. I didn't really touch on this in the presentation, but you know that suddenly to move from 6 million to 17 million doses of vaccine, there are quite long lead times for ordering vaccines. So the supply of vaccines was very tight. Also, it comes at a bad time in the financial year for provinces around affordability. So it was really around affordability and concerns that they may not have enough vaccines quickly enough. That resulted in the decision to delay vaccinating 5 to 15-year-olds. With regards to why did we see more children in the older age group? So our understanding is that it really is a legacy of low immunization rates in the past, low immunization coverage 5 to 10 to 15 years ago, that since then our vaccination coverage has increased, so that younger children were relatively better protected, but that there was an immunity gap in the older children. There is also a concern that it may indicate some waning of immunity, but currently, as I understand, and this is maybe where Kerrigan can comment, we are confident that our vaccine vaccine effectiveness remained high, and that it's more a result of low vaccine coverage rather than a waning of immunity. Thanks.
Dr. McCarthy, would you like to come in?
Oh, thanks, Lesley. I can't really add more than that, other than to say that at this vantage point, when we look back on our data and we see the age distribution of cases, we can't tell whether a person was susceptible because of waning immunity or because they missed vaccination, unless we have very good data from the case investigation form that is supposed to be submitted with the measles diagnostic tests. So at the moment, we're trying to gather this kind of data in order to calculate the vaccine effectiveness using a case control study. But what's really required in order to evaluate or find the answer to this question are seroprevalence studies. And I trust that there are, in fact, I don't trust, I know that there are a number of initiatives led by the NICD at least, as well as other groups. Shbir Mahdi is currently looking at this, that will enable us to make good and informed decisions around the vaccination schedule going forward. Thank you.
Thank you. The next question asks about whether the measles vaccine could be given at an earlier age, considering that some newborns are born with insufficient levels of measles antibodies from their mothers. Prof. Muloiwa?
If anyone can answer it. The balance between giving the vaccine, the timing of it, one is that, if you look historically, the immunoglobulins used to last a bit longer with natural infection. Now, with most mothers having been from the vaccine era, it means that there's a drop much earlier of antibodies. So the answer is yes, 6 months is probably one of the earliest period you can give that. And part of it is to balance two things. One is safety, the younger you are in terms of a live vaccine. But the other thing which is important is also lack of good immunogenic responses because of lack of immune maturity at that stage. So, and in fact, even if you give it at 6 months, you give it in areas that are more endemic because you're trying to protect those who may have very little maternally acquired immunoglobulins. But WHO, in fact, advises that if you can, you need to take that 6 months dose as dose zero, not even count it, because the chance of having poor response at that time and having kind of false security that you've given that dose may be an issue to worry about. So that is an issue that is important. So we are giving it as early as possible, taking into impact issues of immunogenicity, but what we may have to consider going forward, which is what, again, Kerrigan was talking about, that Shabir is even looking at some of that in terms of how soon is immunogenicity falling away. And that may very well be due to our new schedule from 2016, where we are vaccinating much earlier. But yes, we are doing that now with the 6 months program, but it's got the problem of not having high quality immunogenic responses at that age.
Thank you very much. There are no more questions from the floor. So with that, as we come to the end of this important webinar, seeing the recent measles outbreak, I'd like to express my gratitude to all the speakers and to each and every one of you for your participation and your engagement and your commitment to tackling this public health crisis. The knowledge that we've shared today and the insights gained and the connections made are the building blocks for our collective effort to combat measles and its repercussions. It is, however, evident that this is not a challenge that can be overcome by a single entity. It is a collective responsibility that transcends boundaries and sectors. Our goal should always be to protect the most vulnerable among us, particularly our children. The steps we take in our communities, our healthcare systems, and policymaking will resonate through generations, ensuring that they can live healthier and safer lives. As we conclude, let us carry forward the knowledge we've gained in today's webinar and the renewed determination to protect our communities from this highly preventable disease. Thank you once again to all the speakers and to all the attendees of today's webinar. The recording of the webinar will be made available to all. And with that, I'm wishing you a great day further. Thank you so much.